The current pandemic has highlighted the need for healthcare professionals to educate the population at large and serves as a stronger call for developing teaching skills in medical education. In this age of information and misinformation, being able to convey complex ideas and concepts is of higher gravity than ever before. To that end, the University of South Dakota-Sanford School of Medicine has developed a program to prepare physicians for the societal demands placed on them. If one were to, let's see if it'll, there we go. If one were to survey the competencies required at medical schools in the US, they would see a number of things relating to professionalism, medical knowledge, and communication. However, they would see a paucity of competencies relating to education. Therefore, seeking to lead the US and fulfill University of South Dakota's mission to provide quality and broad-based medical education with an emphasis on family medicine, we've developed the following hypothesis. And that is that providing a formal training course, i.e. medical students as simulation educators, for the USD Sanford School of Medicine students on how to become an educator will better prepare them to fulfill the societal expectations for them as physicians. The program in general is broken into two main parts. The first being a series of didactic modules, and the second being the actual reduction to practice of a simulation. We started by recruiting senior medical students to serve as simulation educators. Once these medical students volunteered, we sent them a series of didactic modules that I will go into in a second, giving a foundation in medical education in general and simulation in particular. After the completion of these didactic modules, the simulation educators were able to put their learning into practice by running a series of simulations for their junior classmates, including things such as atrial fibrillation, anaphylactic, and septic shock, just to name a few. It is important to note that while they were running the simulations, they were supervised by a faculty member at all times. The didactic modules consisted of what you see here on your screen. And without going into too much detail, they ranged in topics from the Socratic method to the fundamentals of how to use the mannequin, in our case, the lateral SimMan 3G. These didactic modules were sent out via email to the volunteers ahead of time. And at the end of each module, there was a short multiple choice quiz that was given to assess for understanding. The reduction to practice of the simulation included the students receiving the paperwork for the simulation ahead of time to review on their own, and then a roundtable discussion of expectations and some of the fundamentals of how the simulation would run provided by the faculty ahead of time. After the discussion, the simulation educators were brought into the room, familiarized with some of the equipment that was to be used, and then the junior classmates were welcomed into the simulation area. The simulation educators would provide all roles, all activities and roles related to the simulation, varying from adjusting the vital signs to answering questions provided by the students, and finally conducting a debriefing period where they would talk through what went well and what could be improved on in the simulation. During this time, we monitored a number of different results of the 14 students that participated in the program. First, the junior classmates were assessed both before and after the simulation with a multiple choice test to assess for understanding. Second, there was a learner satisfaction survey distributed to the students after participating in the simulation to see how well they appreciated having a medical student teach them. This information was contrasted against faculty scores and is shown here in front of you. If you look on your left, we have the scores for pre and post scores activities. This indicates the level of knowledge of the junior students before and after the simulation. Looking a little more granularly in the faculty-led bar, the initial scores averaged out to 41.6, and after the simulation resulted in 72.8, showing a net increase in knowledge of approximately 31%. In the student-led, the average initially started at 44.3, and increased to 75.5, interestingly enough, showing the exact same 31% acquisition of knowledge. On the right-hand side of your screen shows the response to a number of questions given to the junior students on a scale of 1 to 5, showing how well they appreciated or they felt fulfilled in a number of different areas. The double-edged sword of the pandemic is that it abbreviated the implementation of the coursework while at the same time highlighting the need for healthcare professionals to be effective educators. However, many interesting things were derived from this project. The first was consistently positive feedback. Both the junior and senior classmates thought it was very helpful for the senior classmates to be able to correlate what was being seen in the simulation to future board questions and clinical connections. In addition, many of the junior classmates commented on the accessibility of role models that the senior classmates provide. Second, it was interesting to see the progression of the use of the training modules over time. While many of the more junior simulation educators didn't find the modules very helpful, over time it was seen that the senior students began to use them to break down the teaching styles into components and use individual models to better enhance their learning styles. It is curious to note that they did shift from strictly mimicking faculty to developing their own teaching style. This supports Kolb's cycle of experiential learning, following from concrete expression to reflective observation, abstract conceptualization, and finally active experimentation. When we previously shared some of this information, Dr. Olvidu Petrus from Romania remarked that he as well was using a similar program to achieve two goals, one being to shore up a faculty shortage, and the second to benefit the medical student instructors. In conclusion, with a proper training, medical students can teach simulation with equal effectiveness as their clinical faculty. Second, there was exceedingly high satisfaction with medical student educators. And third, we feel that participants are better prepared to work with patients, colleagues, and other healthcare providers as a result of this program. Finally, there are two projects that are spinning off as a result of this initial work. One is as a rapid cycle deliberate practice, and the second is students as ACLS instructors. Medical students as simulation educators has made a strong initial step towards preparing medical students to fulfill the expectations of society, and we look forward to future work. I welcome any questions at this time.
Hello all, good morning, good afternoon, and good evening to everybody. I know we're all around the world. So I am discussing interprofessional education curriculum development and kind of the theory and practice and what we have discovered within our school at Sanford School of Medicine. So here's kind of my presentation outline. So first I want to discuss why interprofessional education is important. In 2006, the World Health Organization came out and stated that there is a shortage in healthcare workers and that this is a barrier to providing care to individuals. And so what they think is a good way to mitigate this is to instigate interprofessional education within curriculums. And that this is a way to have healthcare workers collaboration ready as they exit their training to really maximize current resources that are in the field, because we can't necessarily push more bodies into these jobs quickly, but we can really build up and work on the individuals that are already in these spots and really utilize them to the best of their ability. So the goals for interprofessional education are listed here. And the first one is really to develop effective team communication skills. You know, you're working with other specialties, and really developing those skills is important. So second is overcoming those hierarchical statuses. You know, in the past, it's been doctors are at the top of the pyramid, and then, you know, it trickles down. Really, we want to make sure that we are having a team that is seen as equal. There still needs to be a leader to make sure decisions are made and things are done, but really to make sure that everybody is heard and everybody feels that their voice is empowered to speak up. Each specialty looks through a different lens and sees patients' needs differently. And so I think by accomplishing goal number 2 will really help with goal number 3 of improving team-based decision making. Like I said, each specialty sees different needs in a patient, and feeling empowered to speak up will really help make sure that those needs are met and that the proper decisions are being made, especially when they're time sensitive and things of that sort. So here is kind of the process of curriculum development, and I'm going to kind of dive into each individual area. So first, you really need to form an interprofessional development team. This is very vital. So in this team, you need to make sure experts are included for content, education, those who have had experience with IPE, assessment and evaluation, simulation and administration. Each person is very important in their knowledge and experiences. So you need to make sure that each person is seen as equal, just as you're trying to demonstrate within this curriculum you're developing. Within those, you need to make sure that there's representatives from each participating program, especially in the healthcare setting. You know, you need to make sure that those in PA, PT, OT, medicine, that all those schools are being included and have some sort of representation so that their voices are heard. And it's really important in this team to show the qualities and skills that you're trying to demonstrate and achieve within your curriculum. That will trickle down, and it will really create a successful outcome within the activity and curriculum you develop. So next important thing is program evaluation. Now this is one of the more important things, because it really is you trying to identify within the current program what is successful, because you don't want to eliminate those components, what goals you have achieved and what goals still remain there that need to be looked into and figured out what you can do to achieve them, where the gaps are and redundancies within the education, and whether this is from poor design or poor implementation. Are your assessment tools not matching appropriately to measure if your outcomes have been met? Are you implementing it at the wrong time? So you really need to understand your current program to try to help better it. So along with the evaluation, you really need to identify your target audience and know who you are trying to teach, what their knowledge level is, what their skill set is, and what they bring to the table already. Getting to know who you're creating this curriculum for is very important. And with that, you need to look at the program and decide, this is the ideal state of the program, and this is where we currently sit, and what are we missing to get from point A to point B? And that's where the educational gap is. The educational needs is the tool that's used to close that gap, the intervention that needs to be taken to get from that point A to point B. And you can do this with needs assessment of surveys, skills, observations, learner feedback, and you can use these to get to know your target audience as well. The program that I worked on prior to this, we did our needs assessment by understanding students' learner readiness to learn, readiness to teach, their professional identity, and where they sit and where they're ready for IPE to be implemented within their program. And we did this across, it initially started with medicine and then went into the PA, PT, OT, pharmacy programs within USD. And then we even extrapolated that to worldwide in European countries across the United States. And we came up with similar results amongst all of that, which was very impressive. So here you need to identify if interprofessional education is the most beneficial tool to kind of close that gap. Next, you want to generate the learning objectives. And now you want to make sure that you do your evaluations prior to starting your learning objectives and your curriculum content, because you need to know what you're writing these things for. So I just wanted to remind you of the goals of IPE and what you're trying to write those learning objectives to accomplish. Here, it talks about the learning objective types and the different areas that you're looking to meet the educational needs and goals. So for effective IPE, you really want to have two sets of learning objectives. You want to have an IPE related set and a clinically related set. So another component of Sanford School of Medicine is that they implemented a successful ICU bedside rounding activity. And I gave examples underneath of what we were looking for learning objectives. So for our IPE, we're looking at targeting those previous goals that I had of effective communication to achieve the clinical learning objectives, which was exposing the students to an ICU patient and managing their care. So across all this, we're really looking to standardize and create a framework that people can refer to when developing IPE curriculum. And that's a huge goal of this project across the world. We would like to have the standardization. And so Interprofessional Education Collaborative has established a list of core competencies that I highly recommend you refer to when you're developing these learning objectives for your curriculum. So next, you want to develop an assessment tool to measure if those learning objectives have been met and that skill or knowledge has been acquired. So here I have the objective types listed again and the tools that you can use that can best fit those areas. So as Peter had mentioned in his project, they did quizzes and interviews and debriefings for post-activity, and they also did satisfaction surveys. And at Sanford School of Medicine, that is a good foundation of what we typically do for assessment tools, is having the combination of the three. So we get learner feedback, we're understanding their knowledge acquisition, and we're learning their thought processes by doing the interviews and debriefings and correcting those processes where we need to. Maybe their processes is correct in how they're thinking, but at the end they come up with the wrong solution, or so just kind of figuring out where in that timeline of their thought process that we need to correct, and it's done immediately after the simulation activity to ensure that it is corrected. So combinations are probably the best way to do it for IPE activities. And here you really want to make sure that you're consulting the specialists, the educators, and the content experts to make sure that your tool is measuring the learning objectives that you are trying to reach. Next, you are looking at the curriculum content that you would like to develop. And here, it's easy to come up with cases for simulation that you have experienced in your own practice, but this is not always reflective of best practice. So you really want to ensure that the content is valid and evidence-based. Make sure you're referring to the societal guidelines, consulting the experts again, and using best practice when developing your activity to make sure students are learning, one, that you need to make sure you're practicing evidence-based medicine, and two, that they're learning the correct content. Next, the activity needs to be interactive and engaging. By the World Health Organization's definition of interprofessional education, it is an interactive process. You are teaching and learning from one another, from different specialties, and engaging each other. So make sure your content and activity does this. Third, you can have critical performance indicators. You do this by structuring out your activity, and this will kind of provide you a framework of where you should see these expected behaviors, which will easily allow you to create a checklist for observers when you're undergoing the activity and doing, you're using those assessment tools. And you need to know your learner's knowledge and expertise level. This goes back to a very thorough evaluation and knowing your target audience when you're developing this content. That's why you need to do that step prior to this, so that you know and make sure that the level of the activity satisfies the learner's knowledge that they're at. If it's too high, it's going to be above their head. They're not going to learn anything from it. And even if it's too low, the continued exposure helps retention. So sometimes it might be better to aim low and give them an experience than aim it too high and completely miss them altogether, and even hurt their ego and have more dissatisfaction, and their attitudes might be more negative towards IPE. So next is the teaching methods. And the most effective teaching method is the one that achieves your learning objectives. So they're not going to be the same from activity to activity. It's not going to be the same from school to school. You can have a combination of teaching methods that are your go-tos. These are examples that the Sanford School of Medicine does throughout their activities within healthcare programs and for interprofessional activities as well. So simulation, standardized patients, patient-based learning, and journal clubs. Simulation has been seen as best practice, but again, that doesn't mean that it is the most effective method for obtaining your learning objectives. Here at University of South Dakota, we have something called the passport system, and this is how we track students' engagement within interprofessional education. This is one of our teaching methods. And so as soon as a student participates in an activity, they earn a badge for that participation. And after participating in 3 or more activities with various immersion levels, they will be certified with an IPE champion status and issued a certificate. And this is something that they can put on their CV, and it's really beneficial when applying for jobs in the healthcare field, because you're coming out saying, I am a person that can maximize your resources. So I think it's a very beneficial program, and it could be an idea of a way to track your students' participation at your programs. So there's a lot of challenges when it comes to interprofessional education and integrating it, because you're integrating it into many different programs, 3, 4, 10 programs, however many you have that you'd like to be within, activity. And so some of the problems are making sure that all the accreditation requirements are met within each of those individual programs, scheduling, and having that knowledge and skill set of where they're at amongst each individual program, and then all, across all the programs. So some of the solutions that we've discovered here at South Dakota are to make up for the accreditation requirements that differ amongst programs, is kind of to have that core learning with each program. And this is where programs determine the number, the frequency, duration, and at what level of exposure or immersion that they want their students to have for each of their activities. And with that, they can integrate that with students participating in activities, but ensuring that they meet their own requirements. So with scheduling issues, we recommend planning 12 to 18 months prior to the activity to ensure that all the participating programs can try to fit it into their schedule. And then the variation in, where learners are at, it's really important to have that thorough evaluation prior to know, okay, students who are at this point in the nursing program will work best with students at this point in the pharmacy program and this point in the medical school. So, these are the students, this will meet the students where they're at and their readiness to learn and teach, and their abilities to do so effectively with their knowledge and skills. So now we're at the implementation portion of the process, which it's hard to standardize this because it is very cultural dependent, and each program will have to figure out when it's best to implement it themselves. You can evaluate where students are ready for you to implement it to make sure that you're doing that at the correct time. But overall, it could be very dependent on your school culture, your local culture. And so figuring out the best time to do that for your program individually amongst the programs within that you're trying to do the activity with. Then next is the translation to practice. This is also very difficult to standardize and to kind of keep track of, because once students are no longer students and they're in the healthcare field, it's hard to keep track of where they're at. And along with that, the healthcare facility that they join is a culture of its own, and will change kind of what they are doing as an interaction, if it's seen as a positive thing or a negative thing. And there have been studies that have seen, that can have an effect. So this is also kind of difficult to standardize at this point, and an area that will need to be looked into. I really appreciate everybody coming to listen to my presentation and hope that they have gained some sort of insight to a framework that can hopefully be standardized more in the future so that we can all have a great interprofessional education implemented within our curriculum to benefit our students and their communication skills, eliminate hierarchical statuses, and to be able to have the best decision making for our patients.
My title is Introducing Entrustable Professional Activities for Pre-Medical Students in Preclinical Rotations Using Rapid Cycle Deliberate Practice. And essentially, that's just a long way of saying that we are introducing a new simulation teaching style into our curriculum. And a major goal of this project is to kind of teach and help other schools that want to implement the rapid cycle deliberate practice and show them how we did it and help them avoid making the same mistakes that we made. To quickly go over some different simulation teaching styles, you could have one professor to like 200 students in a lecture hall and have the professor show the simulation. So the students aren't going to learn very much that way with no hands-on activity, but it's very time efficient, and if you're short on personnel, it might be necessary. The way we do it traditionally at USD is called high fidelity simulation, and some of the other presenters have already talked about that. But to quickly go over it, it's 3 to 4 students to one professor or instructor, and each student runs through the simulation once, and then they have a debriefing of what they did right, what they did wrong, and then that's about it. So they're going to learn how to do the simulation that way and learn that skill, but they probably won't remember as much, say, 3 years later when they actually need that skill in residency. What the rapid cycle deliberate practice is, it's a smaller instructor-student ratio, so you have 2 students with 1 instructor, and the goal of it is to actually learn the skill and then remember it later. So I'll go over more about what it is in detail in a minute. So I'll just go over the background, methods, what we did right, what we did wrong, and I'll talk about what we learned. So it used to be that once students got into residency, they then learned the skills that they needed. But now it's kind of expected that when students enter residency, they're already expected to know these skills and to be able to do them. So part of this involves the student being trustworthy. So the AAMC has developed entrustable professional activities, or EPAs, to kind of guide this process for medical schools of teaching these skills that the students are now expected to know once they hit residency. A big component of it is the trustworthiness. The student has to be self-reflective and self-aware and know what they know. So if an attending says, hey, go intubate this patient, the student needs to say, or not the student, the doctor now, the resident needs to say, I don't know how to do that, if they don't know how to do that. But hopefully the medical school has prepared them well enough that they do know how to do that. So one way to kind of teach these skill sets is rapid cycle deliberate practice. And it was developed by Johns Hopkins University in 2012. It's a simulation-based teaching method that provides immediate feedback. So as I mentioned, the high fidelity that we traditionally use at USD lets the student go the whole way through the simulation and then tells them what they did right and wrong. With rapid cycle deliberate practice, they start the simulation and then the instructor stops them as soon as they make a mistake. And then the student corrects that mistake and continues on with the simulation. They then do the simulation again and the process repeats until they get 100% correct on the simulation, and then they can do that again and again and again. To achieve this level of mastery, studies have shown that it takes around 6 to 11 repetitions of the activity, and that really depends on how complex the skill that you're trying to teach is. And the 6 to 11 repetitions is important to get that resistance to the rapid degradation. So this way, the students will remember it in the future, hopefully. Whereas with the high fidelity, they learn it, they might not remember it. With the rapid cycle deliberate practice, they learn it and then they remember it. So obviously this is an effective tool for teaching these skill sets that the students need to know for residency, because they'll learn the skill and then they'll remember it later. So what we did is we used it for our airway management course. This is second year medical students. So one of the first mistakes that we made is we tried to split it up into orotracheal and nasotracheal intubations. That took away time that we needed to achieve mastery, complete mastery of the skill. We didn't have enough time to do that. So we had a 2-to-1 learner-instructor ratio. We used medical students as simulation educators, which you heard about from Peter earlier. And performance was evaluated with validated checklists, and we had a 10-point multiple choice quiz to assess their knowledge before the simulation and after the simulation. So before the simulation began, the students were given reading assignments so that they were expected to know the sequence of steps prior to the simulation. And then not only were they expected to know these steps, they were supposed to actually understand them too. So there are a lot of drugs involved. They were expected to know the side effects of the drugs, like if they had an overdose, what you would see with an overdose. We assessed that level of understanding during the simulation while it was going on. So if a student said they wanted to give a certain drug at a certain dose, we said, okay, good job. But what if you accidentally gave too much, and what would you expect to see? What's the overdose from that? So that's how we assessed understanding during the simulation. So like I said, we kind of split up our time. So we only had 30 minutes for each intubation, the orotrach and the nasotrach. We spent 2 minutes with the introduction and orientation, 7 minutes for an instructor demonstration to the entire class, and then 20 minutes divided between 2 learners to practice the intubation. And for every 2 learners, there was 1 instructor, which was the medical student, an older medical student. So it's important to note that the first few practices took longer than the next ones. So the first time they ran through it, it took a pretty long time. They made a lot of mistakes. But as they kept going, they got better and better. And the last ones only took a few minutes, whereas the first ones took quite a while. Specifically, here's the intubation sequence that we did. Intubations are actually a lot more complex than a lot of people think. It's not just shoving a tube down a throat. You have to also give medications. As you can see, there are a lot of medications. They had to know all of these and know the side effects and the dose of all of them. And then they placed the tube, and then they had to know the correct placement of the tube. So they had to verbalize all of these confirmations and verbalize how to check for all of them. So they have another, so we did it with our M2s in their airway management course. And then coming up in 6 months from the initial course, they have another airway management course where we will again do the simulation, and we will see how much they remember. So we will see if we have that degradation of knowledge or not. We are hopeful that they will remember it, although like I said, we were short on time, so they only got 2 to 3 repetitions of the activity each, whereas like I said, we needed 6 to 11 to achieve that full mastery. But we're hopeful that they'll still remember how to do this. And we'll check it the same way with the multiple choice quizzes, but we'll change up the questions so that they didn't just memorize the questions. And then we'll use the performance checklists again. And we'll switch out the instructors so that the instructors aren't just saying, oh, these are the same students, they're supposed to be better. So we'll use different instructors so that they don't know that. So like I said, we're hoping that the knowledge won't degrade and they'll remember how to do the intubations. So this was our first attempt to implement the RCDP teaching style with the simulation. Next time, we're going to only focus on the orotracheal intubations so that we have more time so that they can hopefully get that 6 to 11 repetitions that we need to achieve the mastery. The 2 to 1 learner educator ratio was very appropriate, but we underestimated the fact that the educators require a little bit more training. They had the checklists and they were following along with them, but some of them weren't being filled out consistently, like we would need to collect the data. So we're going to have a more formal training for our educators, but several of them collected the data in a consistent way that allowed us to see, hey, yeah, this is going to work. So I already went over what we plan to do next year to improve it. We did lose some time due to COVID-19 challenges like everybody has experienced lately. And the students reported a really high level of satisfaction from being able to feel like they actually understood how to do this skill and they actually would be able to do it if they were asked to do it by an attending. So students really like that. And then when we do the 6-month follow-up, we'll be able to see how much they remember, which we hope is a lot. So like I said, we need more time and personnel training for this style of teaching, which we will implement next year, but we have enough data right now to say that it's a proof of concept and that it works, and we're going to continue with it. So I will take any questions.